Welcome to The Explainer. Today, we're decoding some seriously complex cardiovascular and neurovascular clinical vignettes. We aren't just looking for the right answers here. We're really digging into the pathophysiological why behind the absolute next best step. So let's bridge that gap between textbook theory and real-world clinical algorithms. We've structured today's breakdown into 5 distinct clinical buckets. We're going to cover stroke and VT, managing carotid stenosis, acute decompensated HF, optimizing chronic HF, and advanced heart failure devices. It's a complete journey, straight from acute crisis management all the way to long-term chronic optimization. Let's kick things off with Section 1, Stroke and Venous Thromboembolism.
Picture this. You're evaluating a post-op patient. Out of nowhere, they develop unilateral leg swelling, warmth, and calf pain. Right away, you're thinking classic deep vein thrombosis, driven by Virchow's triad. But then, the unthinkable happens. They concurrently suffer an ischemic stroke. It's one of those classic presentations that forces us to dynamically link a venous issue down in the legs with a catastrophic neurological event up in the brain.
What we're looking at here is a paradoxical embolism. Basically, a clot breaks off from the deep veins in the leg, travels up the inferior vena cava, and instead of getting safely lodged in the pulmonary circulation like you'd expect, it completely bypasses the lungs. It literally slips right through a patent foramina ovale, a structural defect in the heart, enters the systemic circulation, and shoots straight up to the brain. Now notice the order of operations here, because this is absolutely crucial. You've got a patient with a structural heart defect and a clot. You might be wondering, why not just surgically close that PFO right now? Well, it's because acute stroke management strictly prioritizes rapid neurologic rescue. If they're within that golden 4.5-hour window and have no contraindications, you hit them with prompt thrombolysis using IV alteplase to get that brain perfused again. Only after that do you start anticoagulation, usually a heparin bridge to stop more clots from forming. Leaving the structural repair of the PFO for a later outpatient follow-up is essential. You simply cannot delay reperfusion.
So, the big takeaway? Stabilizing the ischemia and stopping clot propagation takes absolute priority over any structural interventions. If you misclassify the stroke mechanism, you might accidentally just prescribe antiplatelets, which would completely fail to treat the underlying venous thromboembolism, and we definitely don't want that.
All right, moving right along to Section 2, Managing Carotid Artery Stenosis.
When you're evaluating a patient with carotid stenosis, let's say it's a hypertensive patient coming in with a TIA or a retinal artery occlusion, you have to immediately weigh medical management against surgical intervention. If your patient is severely symptomatic with greater than 70% stenosis, or even asymptomatic but sitting at greater than 80% stenosis, referring them for a carotid endarterectomy is your highest yield, most time-sensitive move. But for lesser stenosis or for post-op care, we lean heavily on the classic medical triad: antiplatelet therapy, a high-intensity statin, and strict blood pressure control, usually with an ACE inhibitor or an ARB.
For patients managed medically or those recovering from surgery, clopidogrel is your essential antiplatelet agent. It works by irreversibly inhibiting the ADP-P12 receptor right on the surface of the platelets. This brilliantly prevents the activation of the glycoprotein IB/3A complex, which effectively blocks platelet aggregation altogether. It's a total workhorse medication. We use it not just for carotid stenosis, but also for coronary artery disease, especially after putting in a stent, and for peripheral arterial disease too.
Next up, Section 3, Acute Decompensated Heart Failure.
Let's test your reflexes. You're assessing a patient with profound volume overload. They're hypoxic, visibly struggling to breathe, and you're seeing JVD, hearing an S3 gallop, and picking up clear crackles in the lungs. Basically, they are drowning in their own fluid. What is your immediate pharmacologic move? You absolutely have to reach for IV loop diuretics like furosemide to rapidly clear that fluid. It hits the loop of Henle hard to promote potent diuresis and unload those lungs. Listen, you absolutely do not start chronic mortality-reducing meds like beta blockers in this moment. Starting a beta blocker in an acutely decompensated volume-overloaded patient is a recipe for disaster. It can fatally drop their cardiac output. Contrast this with stable angina, where we'd use sublingual nitroglycerin for venodilation. That reduces preload and myocardial wall stress without aggressively diuresing the patient. And speaking of nitroglycerin for angina, you really need to know how to manage its predictable hemodynamic side effects. Nitroglycerin drops preload, right? Which means cardiac output can momentarily dip. If the baroreceptors sense this and trigger reflex tachycardia, that spiked heart rate actually ramps up myocardial oxygen demand, which is exactly what we don't want, so we layer on a beta blocker to blunt that sympathetic response. Now, if the nitrate triggers severe hypotension instead, you push a bolus of IV fluids to restore venous return. You don't need to panic or order a bunch of advanced imaging. You just need to understand the pharmacology and restore that preload.
That brings us to Section 4, optimizing chronic heart failure.
We all love a good high-yield pattern, don't we? Notice how we sequentially layer guideline-directed medical therapies, or GDMT, to block maladaptive neurohormonal pathways and, most importantly, improve actual survival. We kick things off with ACE inhibitors or ARNs, alongside beta blockers. Then, as massive trials like RAILS and EMPhASIS-HF have shown us, if their ejection fraction is 35% or less, we add a mineralocorticoid receptor antagonist, like spironolactone or eplerenone, assuming their kidneys and potassium levels are okay, of course. Next, we make sure an SGLT2 inhibitor is considered. And finally, we look at specific combos like hydrazine and nitrates for persistent symptoms. It's like building a protective fortress around the heart, step by step.
Now here is a classic trap in clinical management. Please don't reach for digoxin or unnecessarily escalate loop diuretics for a patient who is only mildly symptomatic but clinically stable. Always remember that drugs like furosemide, digoxin, and ivabradine are mostly just symptom-relieving band-aids. Sure, they might keep a patient out of the hospital, but they do not improve all-cause mortality like our core pillars do. The absolute goal is to max out those mortality-reducing foundational therapies before leaning heavily on symptom relief.
When we apply trial data to specific populations, the AHEF trial gave us some incredible insights. It proved that if a self-identified Black patient remains symptomatic despite optimal core therapy, adding a hydralazine and nitrate combination provides a proven independent survival benefit. And the mechanism here is wonderfully synergistic. Hydralazine causes arterial or dilation to drop the afterload, while nitrates cause venodilation to drop the preload. Working together, they dramatically relieve wall stress in that failing myocardium.
The bottom line for chronic management is that you have to aggressively pursue these mortality-reducing medications. MRAs in particular are absolute game changers because they halt aldosterone-driven myocardial fibrosis. You literally must optimize these pharmacological pathways to the absolute limit before you even think about considering advanced invasive interventions.
And that perfectly segues into our final section, number 5, advanced heart failure devices.
So patients with severe HFrEF are at a massively increased risk for ventricular tachyarrhythmias. To combat this, we reserve implantable cardioverter defibrillators, or ICDs, specifically for primary prevention of sudden cardiac death. But here's where it gets interesting. If you look at their EKG and see a widened QRS complex over 150 milliseconds, which is typically a left bundle branch block, it means their ventricles are contracting completely out of sync. In that specific scenario, we upgrade them to a CRTD. That stands for cardiac resynchronization therapy combined with a defibrillator, and it's used to fix that mechanical dyssynchrony and really improve forward blood flow.
The crucial point here is that while medications work absolute wonders to reverse remodeling and block those maladaptive hormones, they have their limits. These devices act as a mandatory electrical safety net when the myocardium remains persistently and dangerously compromised, because at the end of the day, pills can't always stop a lethal electrical storm.
To wrap up this explainer, I want to leave you with a provocative question. Devices like ICDs and CRTDs are, without a doubt, life-saving miracles of modern medicine. But before you make that surgical referral, look closely at their med list. Are you absolutely certain you've exhausted every single mortality-reducing pill, every beta blocker, ARNI, and MRA? Before sending your patient under the knife, you have to be sure, because true clinical excellence is knowing exactly when to rely on the prescription pad and exactly when it's time for the pacemaker. Thanks for tuning in.